What is up, everybody? Piscean here. In this video, I want to talk about detransitioning. So, this is a medical research essay. It's conceptual, but it's on detransition in testosterone-exposed females, including myself, who was on testosterone gel for 7 months at the age of 19 and now has a permanently lowered voice, possibly other health issues, a longitudinal analysis of regret trajectories, endocrine reversibility, and multidisciplinary management. The Journal of Gender Medicine and Reconstructive Endocrinology. This is where it's conceptual because, of course, people aren't going to actually write about this yet. But here's our abstract we'll start out with. So detransition is defined as the discontinuation or reversal, attempt of reversal, by the way, of gender-affirming, quote-unquote, medical interventions accompanied by regret. It is an increasingly recognized but understudied outcome. This review focuses on natal females who initiated exogenous testosterone at varying ages, using diverse administration routes, intramuscular injections, transdermal gels, subcutaneous pellets, and oral formulations, and later experienced regret after weeks, months, or years. We examine the clinical trajectory from initiation through detransition, categorizing regret temporally. Acute regret, which is usually greater than 3 months, subacute regret, which is 3 through 12 months, and late onset regret, which is greater than a year. Key irreversible and partially reversible effects of androgens are detailed, including vocal cord thickening, which is permanent, skeletal changes, which is permanent, and clitoromegaly, which is fucking permanent. Special attention is directed to the impact of administration route on pharmacokinetics and reversibility timelines. Management protocols are proposed for those who underwent masculinizing surgery, such as mastectomies, hysterectomies with or without oophorectomy, metoidoplasty, phalloplasty, and those who did not. By synthesizing endocrine, surgical, dermatological, and psychiatric perspectives, we establish a framework for compassionate, evidence-based care of the detransitioned female. Let's start with our introduction here. The rising application of quote-unquote gender-affirming hormone therapy, or in my opinion, mental fucking illness, has been accompanied by a small but significant population who later regret these interventions. Now, they say it's a small but significant population, and when I say they, I mean I use DeepSeek to help me write this, and I find it very funny that I did because this is just exactly what the government wants us to think. Oh, it's a small, significant population. No, it's a big-ass population that's scared to come out and say they regretted it. And we will see it very, very soon. So excuse any verbiage that sounds like I'm about trans rights, because I gotta be completely honest with you folks. This is all a phase. Like, you would grow out of that shit. You would grow out of it. Life has experiences that it throws at you, but that doesn't mean you react by hurting yourself in such a way that, like, you're literally rewriting your own biology. So female to male FTM spectrum individuals who receive exogenous testosterone experience a cascade of androgen-induced changes with differential permanence. When regret ensues, the clinical picture is complex. Some changes have occurred within weeks and are partially reversible, while others present after months or years require surgical or logopedic remediation. Furthermore, the pharmacokinetics of testosterone delivery, whether via depot injection producing supraphysiological peaks, steady-state transdermal gel, or oral testosterone undecanoate with hepatic first-pass metabolism modulate the onset, intensity, and reversibility of virilization, thereby shaping the detransition experience. So this essay explores female detransitioners, and specifically female detransitioners because I'm a female, through 3 temporal lenses of regret, dissects the influence of testosterone formulation and delineates treatment pathways for both non-surgical and both surgical individuals. The goal is to inform endocrinologists, plastic surgeons, psychiatrists, and voice therapists, and even detransitioners and people that actually want to help us, enabling holistic restoration of endocrinological, anatomical, and psychological well-being. Let's go ahead and talk about trajectories of regret. Acute, subacute, and late onset. So acute regret being around the 3 months mark. So acute regret typically manifests within the first 12 weeks of testosterone therapy. At this stage, irreversible anatomical changes are minimal, except clitoromegaly, which may begin within days to weeks. The primary drivers are psychological and somatic. Dysphoric responses to the initial sensation of hormonal shift, inability to tolerate injection-related pain or gel texture, rapid mood swings, or acute acne vulgaris that precipitates body image distress. Some individuals report a chemical dissociation upon androgen administration, describing depersonalization that contradicts their anticipated sense of authenticity. In those using intramuscular testosterone, enanthate or cypionate, large peak-to-trough fluctuations, serum testosterone rising to 1,000 through 1,500 ngdl at 24 through 72 hours and falling to hypogonadal levels by day 10 through 14 correlate with cyclic emotional dysregulation. Gel users may experience slower onset but can still face dysphoria as skin changes and mild voice instability appear. Pills such as oral testosterone undecanoate are absorbed via lymphatics, avoiding first-pass liver metabolism, but their daily dosing leads to rapid accumulation of something called DHT, dihydrotestosterone, within the first month, hastening androgenic side effects. In this acute window, if testosterone is discontinued, the hypothalamic pituitary ovarian, or HPO axis, generally recovers. Menstruation resumes within 4 through 8 weeks, and acne and mood stabilize with minimal long-term sequelae. But what happens when they keep making people guinea pigs? What happens when the government keeps on making us guinea pigs? Well, we die, first of all, but it's going to be a pretty painful death. So subacute regret looks like 3 through 12 months, and I'm right in the middle of this. It took me 7 months to realize I had to stop. Subacute regret emerges when permanent or slowly reversible changes become undeniable. By 6 months, voice sufficiently has deepened due to irreversible thickening and lengthening of the vocal folds, also known as androphonia. And facial and body hair have progressed from villous to terminal under the action of DHT and hair follicles. The female detransitioner at this stage may experience a clash between her internal sense of gender and the masculine vocal timbre, leading to social embarrassment and psychological distress. Those on testosterone gel may have a relatively lower proportion of DHT conversion due to steady-state kinetics, potentially resulting in slower terminal hair development than injections. But once terminalization occurs, it is equally permanent. Subcutaneous pellets delivering stable levels demonstrate similar permanent virilization without fluctuation-related distress. Yet the consistency of androgen delivery means androgenic alopecia, male pattern baldness, may be more advanced by month 9. Menstrual suppression is often complete upon cessation. Return of ovulation is expected but may be delayed 3 through 6 months, especially in those with pre-existing polycystic ovary syndrome, also known as PCOS. Breast atrophy, reduction in glandular tissue, and increase in fibrous stroma is pronounced but partially reversible upon estrogen recovery, though the original shape and volume rarely return fully without augmentation. For patients who have not undergone mastectomy, regaining a feminine chest, like your breasts, that contour might require time, and if dissatisfaction persists, fat grafting. Moving on to late onset regret, which looks like a year or more of using testosterone as a female. Late detransitioners have sustained testosterone exposure for 1 or more years, often alongside legal gender marker change and social role consolidation. Peak psychosis, in my opinion. Regret may crystallize due to a shift in identity understanding, religious re-identification, chronic health concerns like polycythemia, hypertension, lipid abnormalities, or realization that underlying trauma or neurodivergence was incorrectly mapped onto gender dysphoria. The physical landscape is dominated by fixed virilization, full male pattern voice, dense facial and body hair, clitoromegaly, length exceeding 3.5 cm, frontal bossing if therapy began before epiphyseal closure, and significant male pattern alopecia in those using oral testosterone. Long-term hepatic effects, though mild with modern formulations, may have altered sex hormone-binding globulin, SHBG, and lipid profiles. Surgical regret compounds the situation. Individuals who underwent bilateral mastectomy perceive irreversible loss of erogenous sensation and the ability to chest feed, while hysterectomy with bilateral salpingo-oophorectomy, or BSO, commits them to lifelong exogenous sex steroid replacement, creating a profound psychological burden. Those post-metoidioplasty or phalloplasty face complex reconstructive decisions, if there are any, at this moment in time. Influence of testosterone formulation. Varying pharmacodynamics dictate the speed and permanence of virilization, informing regret profiles. So, intramuscular testosterone esters, enanthate, cypionate, depot preparations with 7 through 14 day half-life, superphysiological levels in the first 48 hours drive rapid DHT synthesis, accelerating clitoromegaly and voice drop. Fluctuations contribute to emotional volatility, which may precipitate acute regret. After discontinuation, elimination takes 4 through 5 half-lives. Recovery of ovarian function correlates with duration of use. Prolonged suppression may lead to transient central hypogonadism, requiring temporary estrogen therapy. This all sounds really scary, doesn't it? This just all sounds fucking scary. Transdermal gel. 1 through 2%. Applied daily, achieving steady state levels. Peak testosterone is lower and DHT conversion is more gradual. Voice changes may be subtler in the first 6 months but deepen cumulatively. Hair and skin effects still occur. Detransitioners using gels often report a smoother transition off, but permanent voice and hair changes are identical. The daily ritual of application can become a psychological trigger for regret as it reminds them of their transition daily, and discontinuation offers immediate relief. Transdermal patches, similar to gel but with a slower absorption, rarely preferred, less fluctuation. Subcutaneous pellets, also known as testopel, implanted every 3 through 6 months, steady release. Regret may be delayed because the individual lacks daily confrontation with active choice. However, when regret emerges, physical removal is invasive and residual testosterone remains for weeks. Hormonal reversal may be slower. Oral testosterone undeconoate bypasses liver via lymphatic absorption when taken with fatty meal, generates a high DHT to testosterone ratio due to intestinal 5-alpha reductase activity. This can cause accelerated and pronounced androgenic alopecia, deepening of voice, and clitoromegaly. Regret after oral formulations may involve a greater burden of irreversible baldness. Surgical context, so with and without surgery. Those that did not have surgery, like myself, the non-operated female detransitioner has structural integrity of breasts, internal reproductive organs, and external genitalia beyond clitoromegaly. Detransition management focuses on the following: seizing exogenous testosterone, monitoring HBO axis recovery, FSH, LH, estradiol after 6 through 8 weeks. If amenorrhea persists beyond 4 months, a progestin challenge or short-term estrogen therapy can restart cycles. Breast restoration, glandular involation may partially reverse. Estrogen promotes ductal regrowth. Fat redistribution slowly returns to gynoid pattern over 6 through 12 months with endogenous estrogen. Many seek chest feminization through fat grafting or implant augmentation due to residual volume loss. Hair management. Terminal facial and body hair requires laser or electrolysis. Male pattern baldness may improve with minoxidil and spironolactone, but frontal hairline recession is permanent. Hair transplantation is an option. And guys, that's another thing they didn't say. Frontal hairline recession is permanent. You will never have your front hairline the same way it looked. Ever again. This is This is the shit that people don't get. Like, we're not being told about this for reasons. Voice therapy. Voice cannot spontaneously rise. Like, I've been to a speech therapist and she said, raise your voice as high as it can go. And I literally couldn't get it higher than this. This is as high as it will go. Behavioral voice feminization therapy, and in some cases, Wendler glottoplasty or cricothyroid approximation surgeries help raise fundamental frequency. Clitoromegaly, reduction clitoroplasty is rarely requested but available if causing dysphoria, and most accept this change as manageable. Alright, with mastectomy only, for those that have mastectomy, bilateral mastectomy removes glandular tissue, often with free nipple grafts that sever ductal and nerve supply. The result is a masculinized chest with scars. Detransitioners face breast reconstruction using tissue expanders and implants or autologous flaps, DIEP, latissimus dorsi. Reconstructive difficulty correlates with the degree of tissue removal and skin tightness. Sensory loss is typically permanent. Nipple reconstruction and tattooing offer aesthetic improvement. Psychological support is paramount, as the final contour is seldom identical to a pre-mastectomy breast. With hysterectomy and or oophorectomy, removal of the ovaries imposes immediate surgical menopause upon testosterone cessation. Estrogen replacement therapy becomes mandatory to prevent osteoporosis, vasomotor symptoms, and cardiovascular risk. Regret over the loss of fertility potential and biological parenting often emerges years later. Oocyte cryopreservation prior to surgery, if available, can mitigate some grief. Long-term management requires careful balancing of estrogen and possibly progesterone for endometrial protection if the uterus remains. To mimic a physiological female hormonal milieu, especially if you want to have kids. With genital, quote-unquote, gender-affirming surgery, which it is not gender-affirming, it's cruel. But I'm just saying it as what you know it as, for right now. Metoidoplasty or phalloplasty represent the most profound modifications. Reversal is extraordinary complex, involving phallic removal, vaginoplasty using peritoneum or skin grafts, and clitoral reconstruction from spared glans tissue. Outcomes are variable and often functionally limited. Multi-stage reconstruction requires a coordinated team of urologists, plastic surgeons, and gynecologists. Many detransitioners with genital surgery choose not to undergo further reconstruction due to surgical risk and psychological exhaustion, instead seeking counseling to integrate the permanent changes into their identity. Multidisciplinary management pathways. We have management of detransition in testosterone-exposed females, and it necessitates a coordinated, non-judgmental approach. Endocrinology weans testosterone, monitors for adrenal insufficiency if glucocorticoids were used concurrently, replaces estrogen when indicated, manages metabolic sequelae. Gynecology assesses uterine and ovarian health, offers fertility consultation, manages vaginal atrophy and prolonged estrogen deficiency. Plastic surgery provides chest reconstruction, hair transplantation, and facial feminization. Voice clinic offers speech-language pathology and phonosurgery. Psychology addresses grief, regret, identity trauma, possible neurodivergence, and provides therapy to reconstruct a coherent self-narrative. Dermatology manages acne scarring, hirsutism, and alopecia. Crucially, all providers must validate the detransitioner's experience without pathologizing their prior transition, fostering an environment where regret is treated as a legitimate health outcome, requiring skilled remediation, not as a moral failing. Female detransitioners who have been exposed to exogenous testosterone, whether via injection, gel, or pills, face a diverse array of physical and psychological challenges when regret emerges at any interval from weeks to years. The permanence of androgenic changes varies with exposure duration and formulation, but virtually all require some restorative intervention. Surgical history amplifies the complexity, particularly mastectomy and gonadectomy. A nuanced, temporally stratified understanding of regret, combined with formulation-specific awareness, enables clinicians to design personalized reversal and refeminization strategies. The medical community must embrace detransition as a legitimate, anticipated variant in the spectrum of quote-unquote gender medicine outcomes, ensuring that those who step away from GAHT are met with the same rigor, compassion, and innovation afforded to those who step into it. Key words here: detransition, testosterone, female to male, regret, voice deepening, mastectomy reversal, hirsutism, alopecia, oophorectomy, pharmacokinetics, multidisciplinary care. And then I would like to give a small little textbook excerpt. It's a conceptual one. It's not a real thing that's been published. Let's say it's chapter 24. We're talking about detransition and the reversal of testosterone therapy, quote unquote, therapy in natal females. From Principles of Transgender and Gender Diverse Endocrinology, a Clinical Handbook, 2nd edition. All right, so here's our learning objectives. Ladies and gentlemen, we're using something called critical thinking skills with our brain. It's a muscle, and it's supposed to be used. So, distinguish the 3 temporal phases of regret after initiation of testosterone in natal females. Describe the differential reversibility of androgenic effects based on tissue type and testosterone formulation. Outline the endocrine management of testosterone cessation in non-hysterectomized versus oophorectomized detransitioners. Summarize surgical options for restoration of feminized chest and vocal characteristics. Recognize the psychosocial dimensions of detransition and implement supportive counseling frameworks. All right? So detransition is not a singular event, but a process that may unfold rapidly after the first injection of testosterone or gradually over years of masculinization. Females who interrupt or reverse gender-affirming testosterone therapy present a unique endocrinological challenge here. The body must be guided back from an androgen-dominant state to an estrogen-dominant milieu, while managing irreversible somatic changes. The chapter equips clinicians to guide such patients through medical, surgical, and psychosocial restoration. Pharmacology of testosterone reversal, pharmacokinetic washout. After stopping testosterone, serum levels decline according to the drug's half-life. Depot injections in cypionate require 3 through 5 weeks for near complete elimination. Subcutaneous pellets may release androgen for 3 through 6 months. Gels and patches clear within days. Residual tissue effects, for example 5-alpha reductase activity in skin, persist longer. Table 24.1 provides average time to undetectable testosterone for each route. So time to serum testosterone, and it's lesser than 50 ng/dL after cessation. So formulation washout period notes: IM testosterone, enanthate, cypionate 3 through 6 weeks. Individual variation with BMI, SHBG. Testosterone gel, it's 1.62%, 4 through 7 days, rapid clearance, steady state falls immediately. Testosterone patch is 2 through 4 days, minimal depot effect. Subcutaneous pellet is 8 through 12 weeks. It requires explant for immediate reversal. Oral testosterone undecanoate is 2 through 3 days, short half-life, but high DHT tissue binding. Tissue-specific reversibility, the voice. Vocal fold stromal changes, including increased collagen and hyaluronic acid, are permanent. Once the fundamental frequency drops below 155 Hz, spontaneous re-elevation does not occur. Management options are voice therapy, lax vox, resonant voice techniques, may lift frequency by 10 through 30 Hz, thyroplasty type 4, cricothyroid approximation, can raise pitch surgically. It is dangerous, though, and expensive if you can't afford it. Body and facial hair, terminal hair follicles do not revert to vellus. Cessation of testosterone halts new terminalization but does not clear existing hair. Laser, alexandrite, diode, and electrolysis provide the only permanent removal. Combination with spironolactone 100 through 200 mg daily or finasteride 2.5 through 5 mg daily can slow regrowth during treatment. Scalp hair. Androgenetic alopecia, once manifests as bitemporal recession and vertex thinning, is largely permanent. Topical minoxidil 5% and oral minoxidil stimulate regrowth of miniaturized follicles not yet lost. Finasteride or dutasteride may prevent further loss but will not regrow fully scarred follicles. Hair transplantation, FUE, offers definitive coverage. Clitoromegaly. Clitoral growth from testosterone is irreversible. It results from hyperplasia of erectile tissue. Reduction corporoplasty is available but risks denervation. Body fat redistribution reverses gradually with re-establishment of estradiol levels. Waist to hip ratio returns to gynoid pattern over 6 through 12 months, supported by estrogen. Breast tissue. Testosterone induces glandular atrophy and stromal fibrosis. After secession, estrogen re-expands ductal structures, but the original volume and contour rarely return fully. Chest feminization may be needed. Fat grafting implants. Bone density. If testosterone was used for over 2 years without adequate estrogen, some loss of trabecular density may occur. Upon resumption of estrogen, DEXA scans show improvement, but peak bone mass deficits accrued during adolescence may not be fully corrected. Endocrine management protocol, non-oophorectomized patient, stop testosterone, measure baseline LH, FSH, estradiol, AMH, and pelvic ultrasound at 0 weeks. If menstrual cycles do not resume by 12 weeks, administer medroxyprogesterone, 10 mg daily, multiply by 10 days to induce withdrawal bleed. If unresponsive, trial transdermal estradiol, 0.05 mg day, for 21 days with cyclic progesterone. Monitor for ovarian function recovery, ovulation kits, mid-luteal progesterone. Most resume within 6 months. If not, evaluate for PCOS or hypothalamic amenorrhea. For those desiring pregnancy, fertility referral. Post-oophorectomy patient, immediate estrogen replacement, transdermal estradiol, 0.1 mg a day, or oral estradiol, 2 mg daily, combined with micronized progesterone, 100 through 200 mg nightly, if uterus present. If hysterectomy with BSO on a post-estrogen is acceptable unless endometriosis history. Titrate to achieve serum estradiol, 60 through 100 pg/ml, monitoring symptom control. Annual DEXA scans until stable. Manage increased cardiovascular risk with lifestyle and statin if indicated. Chest restoration after mastectomy. Women that detransition after bilateral mastectomy confront the absence of breast parenchyma. Reconstruction uses tissue expanders beneath pectoralis muscle, followed by silicone implants. In cases of thin mastectomy skin flaps, a cellular dermal matrix provides support. Fat grafting adds softness and contour. Nipple areolar complex reconstruction uses local flaps and tattooing, but sensation remains absent. Prepectoral implant placement may improve aesthetic outcome. Surgical timing should await emotional stabilization, typically 12 months after testosterone cessation, to allow skin pliability to improve with estrogen-driven hydration. All right, psychosocial and psychiatric support. Detransition regret activates grief, loss, shame, and stigmatization. Validating the patient's evolving self-concept is essential. Therapy modalities include acceptance and commitment therapy, ACT, to foster self-compassion, narrative therapy to reconstruct a coherent life story, trauma-informed care if prior transition occurred in context of abuse, peer support groups specifically for female detransitioners. Clinicians must avoid imposing a retransition pressure. The goal is to help the woman integrate her past decisions into her present identity, not to erase them. Follow-up and monitoring, a suggested timeline. So first month, emotional check-in, hormonal symptoms assessment. Month 3, endocrine labs, voice evaluation, dermatology referral. Month 6, continuous assessment of HBO axis recovery, body image. Month 12, comprehensive reevaluation, including psychological scales, quality of life. Annual thereafter, bone density, lipids, cancer screening, perinatal female guidelines. The care of female detransitioners demands interdisciplinary expertise and profound empathy. By methodically managing testosterone withdrawal, replacing estrogen when necessary, and offering reconstructive choices, medicine can heal the physical consequences of regret while affirming the patient's right to change. Mastery of these principles ensures that the detransition woman receives the same high standard care as any other point in her medical journey. All right. So thank you for watching this video. I hope you learned something. With peace and love, Piscean out.